what we've done is created a model of care that exchanges US dollars for professional services. And the fact that it feels innovative tells the whole story.
It's not about, how can my patients and employees actually get care? They were making decisions based on the premium dollars.
I've literally heard it from the plan level, the celebration of how many denials were placed. That's disgusting to me.
These policies, they trap the very people they're supposed to protect. They were creating a scenario where the patients, their employees, were effectively blocked from getting care. It's optimized for the wrong people. In healthcare, failure rarely looks like chaos. It looks like silence. A patient waiting for approval, a doctor watching the clock. The system hums along, but the person it was built for keeps losing. Hi, I'm Troy Reichert. Along with me is my friend and partner, Dr. Jonathan Bushman. And today we're talking about those moments when patients do everything right and still they fall through the cracks, and what we're learning and how we're fixing that system. Jonathan, how are you today?
Doing well. Thanks, Troy. How are you?
Doing great, thanks. Well, let's just jump right into it, and let's talk about the system and how it's broken down and it fails the patient. So take us to one of those moments when a patient did everything right. They followed every instruction. They trusted the process and still got stuck. What did you see? What did you feel as their doctor and as a human being?
It's a great question, Troy. And then unfortunately, what my mind does to a question like this is it thinks so much more broadly than
Yes.
a single patient experience. Because to me, when you ask that question, I'm thinking that's the whole system that I left in the
Right.
traditional model. Like that's why I left the traditional model, was because
Absolutely.
patients were doing the right thing. So like, for instance, and like this is like an everyday occurrence for patients, specifically in a fee-for-service, busy, hard to get into type practice. So you do the right thing. You wait until 8 o'clock to call the office, and it doesn't go through the first time. You get into the phone tree. You can't get a live person. You call back for the second or third time. You finally speak to someone at the front desk, and through this series of conversations, you realize for your acute illness that this is Thursday, and we have an opening next Wednesday at
Right.
2 o'clock.
Yep.
Okay, that's not helpful.
No, I've got to go the whole weekend without getting care.
Right. And so, okay. Well, let's back up. You have nothing else available. No. Well, what are my options? This is my doctor I'd like to see. They know me, right? And I called immediately, first thing in the morning, because I'm sick overnight. And that's what they get. And they've done the right thing, right? So then they go to urgent care. Okay. Well, guess what? I'm going to be out of work, or in the case of a sick child's going to be out of school. Now the parent's out of work. Okay, what do we do now? And so they do the next best thing. Let's go to urgent care. So we're going to see somebody we don't know. We're waiting in a room full of sick people, or perhaps sick people. We paid a copay, waited an hour, hour and a half. Now they're going to swab us for every communicable disease known to man, so that we can add that to the billing codes. And guess what? We tested negative for most, maybe all of it. And ultimately we're told we have a respiratory illness, but here's an antibiotic, which may not even correlate, but that's what we get. So then the same patient calls back and says 2 days later, should say 3-4 days later, on Monday, they call back and say, hey, I went to urgent care on Thursday after I couldn't get in and I'm not feeling any better. Can I get in? Yeah, we can get you in a couple days. Wednesday or Thursday. Okay, finally. So they show up and either they've gotten better, or you realize that the treatment plan given to them through urgent care, which is based on a very quick visit with no relational basis to it, was off the mark. They did what? They prescribed what? Tell me your symptoms again. I can't tell you the number of times, Troy, that I've looked in ears of children who are following up from urgent care for acute otitis media, an ear infection. And I'm 24 to 48 hours post urgent care visit, and I look at pristine ears. Pristine.
There's no way they had that at the start, right?
I have seen plenty of post-infectious looking tympanic membranes, eardrums, right? I've seen plenty of 'em. I know what they look like, and you look at it and then I'm in that moment, I'm a little bit, torn professionally too, which is like, I wanna tell the patient the truth, like, "These ears don't look like they're infected, but I don't want you to distrust the system that you just went to, but you know what? You went to that system because I couldn't get you in time when you did the right thing, and you called at 8 AM last Thursday morning because I was too busy, I didn't have time." So you can see how this snowball effect of, okay, but here's my frustration. X patient says, "You do realize they take like $387 out of my paycheck every month for this benefit?" And so I have this card. Does that not mean that, like, why do you have a problem getting me in? And um I know this is somewhat of a fictitious story for this moment, Troy, but I'm speaking of it in such a broad term because this was like constant. I heard these stories and witnessed these stories constantly. It was very frustrating for the patients. It's frustrating for me. And I'll go one step further there, Troy. This is where it gets really bad, at least in my impression. So let's say that patient does get into my schedule, and because they're getting into a busy schedule, and I've tried to work them in, trying to do the right thing for the patient, I'm an hour and a half behind on my schedule. They've paid their $35, $50 copay to see me. Mom or dad's taken off work to take the kid out of school and come sit in our waiting room. They've waited in the exam room for 20 or 30 minutes. I finally walk in. I don't sit down because I don't have time. I take a quick glance, see what the problem is. Now, here's the trouble. A simple visit is like a 99212. We call that in healthcare billing codes. It's a 99212. It's an established visit, low complexity. Okay, that's necessary care. Unfortunately, and from the moment we started learning how to code and how to take care of patients in medical school and residency, we learned these sorts of things. That what makes a visit a higher complexity visit? Well, if you order a test, which by the way, urgent care won't hardly let you through the door without ordering
Right.
tests.
Yeah,
If you order a
exactly.
test and you have to interpret data, even though a negative strep test could be interpreted by anybody, you're interpreting data, your medical decision making's gone to a higher level. And that now is a 99213. In real dollar terms, we've probably at that point close to doubled the amount that we would be reimbursed for the visit. Uh, But if we find one additional new problem in the meantime, that's two extra diagnoses, two extra pieces of medical decision making, two extra pieces of higher complexity visit codes. Now we're at a 99214. We've literally nearly tripled the reimbursement for the same service and hardly done anything different. So to go back to your question, I know what you asked me was like, uh, where the patient does everything right. Yes, the patient's just being a patient.
Right.
They
They just
call,
were looking for care.
they showed up to be seen like you told them on the schedule that you told them. You may have not seen them on time, and then you prescribe, you either order a test or you prescribe medication. They're doing what you've asked them to do,
Mhm. Right.
never understanding the whole process behind why it's done that way. And this was life as usual. This was business as usual, and in many cases, I mean, um, fault me for this if you need to. That's fine. It was just good business, right? Um, here's the rules you play by. Here's the
That's right.
coding. Here's the diagnosis codes, the procedural codes, the billing codes. This is how you get paid. This is how you do the work. And without even realizing it in my training, I was learning how to play the game. And patients weren't doing anything different. They were none the wiser.
Yeah.
And
Right.
I wasn't really operating with a conscience toward the patient's financial needs and or the motivations or incentives that were driving me. And when that started to take place, when I started to understand that, um, I'm not even kidding you when I'd say I would lay awake in bed at night and think about the various people I saw that day and did my coding, did my billing, would it match the highest levels of care and standards, and I would always find a way to justify it. Well, no, that's the rules. And so I'm playing by the rules, but why does it feel so wrong? because I'm
Exactly.
doing it to benefit the billing. So am I doing this for myself? Am I doing it for the business that's employing me? I'm definitely not adding billing codes for the patient's sake. So what is it? And I'll be honest, that's one of the biggest drivers as an early professional that made me start questioning what I was doing and the system in which I was working.
Yeah, exactly. Well, and when you think about, you know, the focus of what you're doing, the incentives that you're, you know, basically tasked with, both patient care and from your employer standpoint, sometimes those came at, you know, great odds. And I know that from the insurance standpoint and on the brokerage side, you know, and there were times when I would sit there in front of prospective clients, and all they're concerned about is the money. Okay, it's not about, you know, how can my patients and how can my members, how can my employees and their dependents actually get care? How can they access it? They were making decisions based on the premium dollars. And certainly they had to be aware of that. They had to be concerned about that. I understand that. But they were always, you know, thinking about, okay, what is the bottom line dollars? Okay, well, I can't afford that. So let's just up the deductibles, up the copays. And effectively, they were creating a scenario where the patients, their employees, their members, their dependents were effectively blocked from getting care because they had a high deductible plan. They had to pay everything out of pocket before they met the $5,000 deductible. And then what happens? They don't go until it becomes a really bad situation. They go to urgent care, they go to the emergency room because they have to. And then they're faced with the scenario you just talked about, and they don't even know it. And unfortunately, you know, it's crazy. You know, I was actually with someone today. I was at a dental appointment, and she was talking about how she went to a local hospital for a situation, and she followed the instructions. She had her medical ID card. She gave it to him, and the hospital said, "Okay, no problem. Go see this specialist." And the specialist said, "Oh, that's great. All you need this." And shows they scheduled the surgery. Did she know it could have been outpatient or actually done in the doctor's office? No. He, of course, scheduled it in the hospital. And when she was all said and done, she's like, okay, my out of pocket is this, and my deductible is this. So, okay, I should be maybe a few $100, maybe $1,000 out of pocket. When she got everything said and done, she owed $6,000 because she didn't know the right question to ask. She
Which
didn't
was
know what they were doing. What was it? Very simple procedure, but the doctor was out of network. The doctor that the hospital who was in network referred her to. $6,000 out of pocket because they referred her to the doctor that they wanted. And it happens all the time. So we're talking about this system. And you talked about it from medical school, from your residency. You're trained in this system. And you and I have talked extensively about this with the procedures, with the rules, everything that the doctors live in, the hospitals must follow, every medical practice that they're immersed in. Tell me this. These are policies, these are procedures, and everything sounds noble. Prior authorization, quality metrics, utilization review. But sometimes they trap the very people they're supposed to protect. What's one of those rules from your perspective that ends up doing harm from your perspective for the patient?
well, yeah. I mean, and as you know, any one of them can and have played a part, not a positive part. And we've been on the side of the fiduciary responsibility of looking over these numbers and saying, hey, these things are in place for a reason, and unfortunately, that reason is because there's bad players out there who will waste your healthcare dollars, right?
Yes.
So, I mean, there's good reason for prior authorizations. They don't have to be punitive. Utilization review doesn't have to be punitive.
Right.
Um, but ultimately, the question that keeps coming up when we look at those things is, what what's the ultimate goal here? And you know this as well as I do, but those conversations of the people involved in the process, um, I've literally heard it from the plan level, the celebration, if you will, uh, of how many denials were placed,
Right. Right.
initial denials of care, or initial denials of prior authorizations, as if that was some benchmark they were looking for, right? That's disgusting to me. But we've also been on the good side. We've been on those conversations with the PBMs that say, hey, this prior authorization is in place for the following reason. This is what we want to help the patient achieve, period. So it is patient oriented and again, not meant to be punitive. And I mean, yeah, there's a lot of those rules. I mean, my personal rules, and anyone who knows me or knows me very well has heard me talk about quality metrics and the joke that is. I mean, it's like you could come up with two other better four-letter words to describe it. But they're like, what does that even mean? I mean,
Yes.
you and I were on a call with an underwriter this week that said, you mentioned quality. Can you define what that means to
Yeah.
you? Because, okay,
Exactly.
this is literally the guy that's underwriting the risk of a group, and he's going, what does quality mean? Who wants to define that? And who
Yeah,
gets to
absolutely.
define it? And, uh, take off the layers of a contract, whether it's a value-based contract or otherwise, or even a compensation contract for a physician in an employed setting, and somehow their payment is tied to a quality metric. Who defined the quality metric, right? I've been in that
Absolutely.
contract before. I've been in a contract like that before, and we had 5 different metrics. It made up to what they called a bonus. You could get up to 12% bonus if you met those quality metrics. Kind of interestingly, the math on that was they took 100% of your expected earnings, decreased it by 12%, and then offered this bonus of 12% of the 88% if you met those. And I'm like, okay, you just told a group of physicians who have a generally high intelligence, hopefully. I mean, I think they do. You just told them if you reduce 100% to 88 and then give 12% of the 88 back, that you're going to somehow get to the original 100%. I know we're not mathematicians, but we're not that
Yeah,
dumb either.
for sure.
You just gave us a pay cut and then told us we could get part of our check back as a bonus. Okay,
Yeah.
whatever. But these quality metrics were determined by somebody somewhere. And one of the things that concerned me in that was who determined that?
Mhm. Right.
Okay. And in the case of an employer, hey, you know what? I think they have free reign. If they tell you these are the important things that we want to measure in terms of the overall health of our employees and the outcomes that they have, um, I think we should listen. Employers are paying a big part of the bill. We should listen. In the case of my contract that I had previously been in, my guess is, because it wasn't in full disclosure, my guess is that there were some payor contracts involved that had tied some overall payment to the system on those same metrics, or they were reporting them to somebody that wanted those metrics. But how did it actually affect patient care? It didn't change medical recommendations. It didn't change the USPSTF task force
Yeah.
recommendations. It didn't change how I thought about providing excellent care. It didn't change whether I wanted to manage a diabetic and get their A1C in a good spot. It didn't change that I wanted to screen for breast cancer or colon cancer. It didn't change any of that. What it did was it put a measure on me, and somehow then my quality was measured based upon the percentage of people that would either meet the mark of A1C, have the colon cancer screening, have their breast cancer screening. Um, I can't remember the other couple at the time. But again, you ask the question, when do these things get in the way? Well, they get in the way when all of a sudden you start realizing that somebody who doesn't meet the mark somehow keeps you from receiving your full quote unquote bonus. And that's a problem. It's a problem because this is at the end of the day, it's relational, and I care about patients. I care about uh, managing and rewarding their autonomy. You know, I tell my patients all the time, you don't get to choose how you die, but you do get to choose how you live.
Yeah.
I'm
Absolutely.
there. I'm there to be a partner in this. I'm going to provide you my best recommendations. Uh, but at the end of the day, you have autonomy. Now, from a plan perspective, I know this is where we get to live sometimes. It's like, okay, if we're going to set up an incentive within the plan, if that incentive is driving good, healthy behavior, and you have a financial incentive or reward when you choose those healthier behaviors or healthier options, again, that's promotion of the patient, right?
Absolutely.
It's not a punishment. Um, and we talk about that all the time. We can set an incentive that gives a reward when they make a good choice, but we're not trying to create a punishment when they just make their choice.
Absolutely. Well, you're talking about the bureaucracy that's built into the system, and who does the bureaucracy serve? It doesn't serve the patient, it doesn't serve the doctor, it doesn't serve the plan. And, one of the great things about what the work that you and I do with these, medical plans is that the plan gets to choose. The leadership of the plan gets to choose. Hey, we don't want that thing pre-authorized. Just let them go and get it done. We want this to be controlled. So there's ultimate customization for what purpose? To help the member get the care they need at the right time, at the right place, at the right price. And that's what's so awesome. I think that's what's so great about what we do. Um, when you're talking with an executive that's never been in the exam room, they're not a doctor. They're some kind of manufacturing executive. There's some kind of architectural firm, whatever. But they're an executive. They've never been a doctor. How do you help them understand how you feel or how the patient feels uh, without turning it into a blame game? We're talking about a lot of good people with wrong incentives. And how do you get that executive to understand, hey, through the plan design, we can align these incentives? Tell me a little bit about that.
Yeah, actually, I think the easy answer to that is making the distinction between healthcare coverage, insurance coverage, and healthcare access slash care, right?
Yes.
And making the distinction between what is a financial tool, protection, versus the delivery of care. And unfortunately, that's a really easy thing for the employers and people sitting at the boardroom table. They forget that. They look at the plan documents, they look at the plan design, they look at the out of pockets, they look at the copays, all of these various different things. Nobody at the table is talking about how long does it take to get into primary care? What percentage of our population has primary care? If they don't have a primary care, how do they get a primary care? Have we aligned ourselves with a system that will make sure that our people
Mhm.
have a place to go when they need the help?
Right.
Because ultimately, where's the higher cost of care? The lack of primary care. That's it. That's the
That's the
primary
entry
driver
point,
of high
isn't it?
cost.
Yeah.
Exactly. So there's two things that happen. Either when you don't have great access and and we provide to employers essentially guaranteed access and same day or next day access. What's the value of that? Well, when I talk to an executive, the value of that is they're not off your clock, they're not absent. They have a place to go to get the care when they need it. And they're able to get back on the clock quickly or get well quickly.
Yes.
And they're incentivized to do that because we're staying out of urgent care, we're staying out of ER, we're staying out of unnecessary testing, staying out of unnecessary absenteeism, all
Right.
these various things. Now, one extra level of relationship and value in that equation for the CEO or CFO is when your people know that you have procured a benefit, a true benefit, not a paying mechanism, but a benefit of care, the value of the relationship they have to you as an employee goes up as well.
That's right.
So
Absolutely.
it's translating that in a different way that there's no other broker that's coming in and saying, hey, let me talk to you about this care, this delivery of care that your people are going to have access to easily.
Yeah.
It's
Absolutely.
never that. It's usually the product of look at this suite of products and the price tag, if you will, and the out of pockets, and it's all that mumbo jumbo. And we kind of like, who cares?
Yes.
We shouldn't have to care about that unless things really go wrong, unless we really have a need. And so that's the difference. It's a very primary care led conversation and the importance of primary care.
Yeah.
Um,
That's
you know,
great.
I was speaking to the CEO of a company that has a lot of well, they have a fleet. They have a lot of assets that are going over the road, and I kind of tongue in cheek said, "Hey, I've got this cost containment strategy for your business I've been thinking
Yes.
about." And they're like, "Oh yeah, well you're not really in this kind of business, right?" And I said, "No, no, no, but I have this figured out. As a primary care doctor, I've figured this out. So what I think you ought to do is just do away with you have fleet management." They said, "Yeah." I said, "I don't think you should do fleet management. What I think you should do is you should contract with the very, very best over the road, side of the road help. Your AAAs or some type of service that can be on call when you have a blowout or can be on call to come fix an engine that's,
Right.
giving you
When your
trouble.
battery's dead, whatever.
And much to my happiness, they looked at me funny. Uh, that's what I was looking for. Like, look at me funny here. They said that doesn't make any sense. We don't want to have those kinds of issues. We've got things to move, right? We've got to keep things moving. And I said, okay. I said, so, but now I'm curious. It was like, what is your health plan? So your health plan, you have a health plan for all your folks, right? Yeah. What is your health plan doing for its fleet maintenance?
Yes.
And that's the real face I was looking for, was when that kind of sunk in. We don't have fleet maintenance for our
Right.
people. Really?
Absolutely.
Well, what do you do for primary care? That's your fleet maintenance. And, we look at different risk management strategies in business and finance, all these different things. And what employers have consistently missed, and it's not their fault, mind you, because traditionally brokers have brought them products that has nothing to do with care,
That's correct.
has no specific tie to care. It's not their fault. But what they've been missing and what we're trying to fill the gap in is that primary prevention, that fleet maintenance, if you will. Hey, let's take care of your people. Let's make sure their primary care needs are met and they have a medical home. From there, things get a lot easier. We stop
Absolutely.
worrying about the out of pockets as much. We stop worrying about the copays as much because we can eliminate that. We can
Mhm.
eliminate the
Correct.
incentives for the billing as well.
Absolutely. Well, you brought up an important point, and I want to highlight that because, about 18 months ago, you and I were at an event, and they were giving away T-shirts, and the T-shirt said, "Health insurance does not equal health care."
Mm-hmm.
And so often we don't understand in that room, in that executive, boardroom, they don't distinguish. They don't understand that. Okay, yeah, I'm buying health insurance. That's the way I'm financing health care. And health care is not health insurance and vice versa. We are talking about how can we set up these programs? How can we set up these plans? How can we give people access to care that is health care? Insurance is just the way we finance it. And I think you brought up a really important point that, hey, those two things are different. And we've got to think about that. And we've got to help our people understand that, yeah, we got to pay for all this some way. But at the end of the payment is care. And if you don't get the care, we're spending a lot of money for nothing. And I
Mm-hmm.
think that's a really important point to help people understand.
It's funny as you say that it was making me think of this time of the year we have a home show. And I love going to the home show. It's pretty neat. You'll have everything from roofers to contractors of various
Hmm.
different sorts at the home
Yep.
show. They've got new products that you can put, whether it's exterior features, interior features. You've got people with furniture. You've got people all kinds of different
Right.
things. You know what's absent at the home show?
What's that?
Home insurance agents.
Sure. And why is that?
I don't know, but I just find that interesting. You go to a healthcare conference and guess what? There's insurers everywhere. They all want to sell
It's
you the
all about
product.
insurance, right?
Yeah, they want to sell you a financial product to protect you
Right.
against
Yep.
whatever or anything and everything, right, under the sun. You go to a home show, which we all have home insurance. You got to carry home insurance. You better carry
Hopefully,
home
right.
insurance. There's a risk involved there, but yet you go to the home show and what are we focused on? Everything from maintenance, home improvement, building, rebuilding, remodeling, all these different things. And that's why it's so much fun. Can you imagine trying to go to a home show and half the vendors were insurance agents?
Yeah. No one who come.
No. I'd be like, thanks. Yeah, thanks. No
Yep.
thanks.
Skip
I'm
that one
good.
for
I've
sure.
already got it. I
Yep.
don't need to talk to you. Yep.
Well, Jonathan, give me one story where a change, either in a conversation, in a form, in a workflow, literally turned around or changed the patient's experience right in front of you. And what did that moment teach you about how close we're getting to making things different in the health system?
And again, if I come with a specific example, I'll do that. But keeping it broad for a moment, that's kind of my everyday. Um, it's a very common occurrence because we've redesigned the way we do primary care through direct primary
Right?
care. I have more time in those appointments, so it's a very common thing for me to establish a plan with the patient about what's next and literally hit pause in the conversation with them, pick up my phone and call the specialist right there, or call the imaging center and say, hey, do you have an opening for this? Or it's very, very proactive. Not only that, we have an in-house pharmacy. And
Right.
more than the majority of the time, what I'm prescribing is generic medication. And in many cases, I'm telling them what our treatment plan is going to be. Meanwhile, I'm putting it in my EMR as I'm telling them, sending it to my in-house pharmacy. My staff sees that it comes up in the queue, and they're knocking on the door a few minutes later with the prescription in hand for me to label it and hand it to the patient. I mean, you talk about compliance with medications, the ability to deliver on a plan. Um, and funny enough, once the patients have gotten used to that, you don't see the amazement on their face as much. But the first time you do it, the second time you do it, they're just like, "Oh my goodness, that's so fast." Like,
Well, think about the
how does that
convenience
work?
factor. They don't have
Mhm.
to wait for that to be called into the pharmacist. They call the pharmacist. Okay, do you have it? No, we don't have it ready, Mrs. Smith. Come back in a couple hours. Think about that convenience. It's right there. If they need to get the meds on board immediately, guess what? It's right there. They can go out to the car, take a drink of
Yeah,
their water, and it's done.
absolutely. We work with Health Rosetta, and Dave Chase is, constantly speaking about healthcare being local, and I've adopted
Right.
that phrase as well. I talk to the people all the time, both our local employers, our hospital administrators, anyone in this local market. Healthcare is local. When you need something, you need to be able to get it. One of my partners was moonlighting in urgent care that he's helped out with some, and he did this last weekend. And he came in Monday morning, and he goes, "Oh my gosh, this it was it was rough." I said, "Why? Did you have a lot of people?" "No, it was slow, and then it took me 15 minutes just to find a pharmacy to send a Z-Pack to for a patient, and he ended up having to drive 25 minutes in a one direction to get to
My
that
word.
one pharmacy that was open in rural Oklahoma at the time." And he's just like, "How is this possible?" And, he's become so accustomed to having that on hand. Here you go. Here, 3, $4 later, and you're treated. And he went he went to this other model for a day and is helping them out, and I'm glad he is. They needed the help, and I'm glad he's there. But yeah, he was recognizing how different that was and how spoiled he had become as a provider to be able to give it so quickly.
Absolutely.
A couple of years ago, patient and neighbor and friend of mine called up, said, "Hey, my wife's looking to have this elective procedure. It's a surgical procedure, and she's going to need a consultation. She's going to figure out what hospital she's going to go to. And by the way, we're on a health share, and so basically we're eating most of the expense of this. Can you help us out?" I said, "Sure." Then, mind you, Troy, this is 11:15 in the morning. He calls me. Um, it happened to be a gynecological question, and I happened to be leaving my clinic in 15 minutes, and I was going to be in the same building as a gynecologist. Again, healthcare is local. I'm in a small community,
Right. Right.
right? So he calls me. I said, "What were you quoted at the hospital?" He tells me 12,500. That was for the hospital, which was about 10, anesthesia, and the surgeon was going to be about 12,500. I said, "Okay." I said, "Give me a moment. Let me message the gynecologist," which I did. "Would you be willing to do the procedure at ASC?" "Yes, I would." "Awesome." Um, Message the administrator. "Hey, how much for this particular service?" I looked up the CPT code. It didn't take me long. Here's the code. "Can you give me a price?" 15 minutes later, I'm in the building with the gynecologist. I step into his office, said, "Hey, local administrator said we can do it over there." All in, $2,500.
From 12,500 to $2,500 in 15
$2,500.
minutes.
Took me about
Couple phone
15
calls.
minutes. Couple phone calls. That's it.
And why is that? Because you
Yeah,
knew the questions to ask and you knew who to call.
exactly. Exactly. And that's, Troy, again, we talk about this is our lives, right? But working as a fractional medical advisor for employers, this is exactly the kind of value that I can give at any time. Now, the caveat to that is your plan designed in a fashion that we can actually go do
Right.
that and spend your money like that
Absolutely.
without violating some contract that you've signed with Blue Cross or United or Cigna? And unfortunately, the answer to that question is in many cases no. We can't do that
Right.
unless we
Can't do
just
it.
spend money outside of your plan. Uh, and you can, but you know, the plan wasn't designed that way. But yeah, that's the kind of stuff that we can do, and in many cases, we arrange those well in advance of the need ever even coming up.
Right. Absolutely.
But guess what? When the need comes up, we're one phone call, two phone calls away from making it happen, and that
Absolutely.
to me was really exciting to make the phone call then to my friend's wife, and it's like,
Oh,
hey,
right.
uh, so I have some news for you. They're like, yeah, brace yourself. It's going to be $10,000. Really? So you got $2,500? I said, no, $10,000 less. It's $2,500.
Right.
Like,
Right.
what? Yeah, it's incredible.
That's awesome. Well, Jonathan, when we go out and we design these programs and a company buys it, the CEO, the CFO, the leadership of the company says yes, and then we're faced with installing this. We always get those questions. The employees are all like, "Oh my word, we don't have Blue Cross, XYZ, whoever that is on the national network. We don't have them anymore." And there's just this fear and trepidation. And they're like, "Oh my word, the company's, gonna limit our benefits. We're gonna cost more money." They're just really scared about what this transition means. And at the same time, when you realize, and when they realize, the employees recognize, oh, wait, this isn't what I was afraid of. And it may take them a few months. It may take them that first procedure to go through and realize it's different. I mean, I've come out of open enrollment meetings where we've explained it to people, and at first they're all freaked out, but at the end they're all like saying, "Yes, I get it. Okay, we'll do this." And I remember one time we were down in Oklahoma City and doing this open enrollment meeting, and after the second group of people were walking out, we heard these two young women say, did they just tell us that we get free healthcare? Because basically through the plan design, if they called the nurse navigator, if they went to the direct contract, if they followed our instructions, it was zero out of pocket for them. And they didn't have to spend the $6,000 that, my dental hygienist paid because she didn't understand that she was going out of network, even though the hospital told her to go to this doctor. We help them understand it's zero out of pocket with the right plan design, with the right incentives, and with the right relationships. You're exactly right. So that's pretty exciting. Well, if there's people out there listening from all over the country, and some DPC doctors can't prescribe medicine in certain states, so there's certainly some of those nuances by region, by location, by state, by regulation. But if you had one thing to tell people about what's the most important thing for that patient doctor relationship that you can make a decision about today, what would you tell them to do? What would you tell them? What question would you ask them to think about? How can I make a change in that patient-doctor relationship?
So yeah, and I would say for the sake of the conversation, employers are a great place to start with that. So if I had an employer in front of me, what can you do? What
Mhm.
question should you ask is,
Right,
do my people have a place to go?
right. Absolutely.
Do they have care when they need it? And where can we get that? I have a gentleman runs a local business, and he's okay with me sharing this. He runs a local auto dealer. Um, Part of their benefits is free access to our clinic, direct primary care. And we started with them a little over a year ago and had good adoption. People were coming in, less than 50% in the first 3 or 4 months, but at this
Mhm.
point
Right.
we have a large percentage of their people. We take care of them, and that's dispersed amongst different clinicians here in our clinic. But the business owner lives out of state and was home visiting and gave me a call, and he said, "Dr. Bushman, I want to tell you I've been in the business all my life, over 30 years of doing this. Benefits has been one of those things over the last 20 years that's just the bane of existence. I hate it. I don't. I hate the healthcare system, everything it represents. It just bothers me." But he said, um, the single best decision we ever made was to start working with you. He said, I've never had so many employees thank me for something that we added to their benefits than what you're doing for them. And I took the compliment, but I also gave it a little bit of credit to say, hey, listen, this is more than just personal. It's more than just the relationships with the employees. What you're saying is when you know that you've spent money in a place that literally gave the care that your people needed,
Right.
it was valuable to them. It was meaningful to them. It made an impact in their lives, in their families'
Yes.
lives. And one of the greatest compliments you could ever hear as a business owner, but even as a physician, one of the
Yes.
greatest compliments you could hear somebody who's paying the bill, the employer itself, who said, "Hey, I've paid for all of this because I wanted to make sure my people had good care." Um, it's a statement to his employees, and it's a
Absolutely.
reminder to us that of course, we're accountable to them, we're responsible to them, but that accountability was met so easily with just being accessible
Exactly.
and getting their people in and taking care of them, and it's almost too easy in some ways, Troy. It's almost a shame how easy it is.
Mhm.
I've heard this term over the years that what we're doing is innovative. And I even had a business coach, professional business coach, in a public meeting, ask me that question: "How did you come up with such an innovative model of care?"
Yeah.
And I said, "Well, let me say firstly
Uh,
that I'm an early adopter. I wasn't the innovator. I'm an early adopter. But secondly, the term you use, innovative, I find that really, really interesting because what we've done is we've created or recreated a model of care that exchanges US dollars for professional services. The rest of the economy calls that a free market.
right.
There's nothing there is nothing innovative about that whatsoever.
Right. Right.
And the fact that it feels innovative tells the whole story.
That's right. Absolutely.
How in the world we went from service to US dollars and it was that simple and it was that innovative? Yeah, crazy. Crazy, crazy. I'll never forget that. One of the best questions that was ever asked, and I'm glad it hit me sideways like, what? How in the world? Um, but yeah, that's what we've done. We've simplified care, we've simplified access. And when we have the incentives straightforward, nobody loses, Troy. I have yet to have an employee say, I just don't understand why my employer thinks that I should come here.
Yeah.
I've never had that experience.
Right.
Well, they told me I have to see you. Oh, okay. You called 30 minutes ago and you're here now being taken care
Right.
of. So
Oh,
yeah,
unheard of. Right.
right.
Well, when you
Um,
think about it, Jonathan, so access to care, they have value because again, we all pay a lot of money for access to care, but we're showing people how to have access. And in some places, it's almost immediate access.
uh-huh.
We're showing people how you're going to see value because we're going to keep money in your pocket. And all of that's part of the transparency model that we're building every plan that you and I are part of into the system. And in my world, we're in the baseball season, we're in the World Series now. It's the classic triple play. I mean, triple plays are, very rare in baseball, especially Major League, but they happen. But we're trying to create a triple play every day. And what do I mean by that? It means that the provider wins. They're getting paid fairly. They're getting paid quickly. The patient wins because they have access to care or keep more money in their pocket. And who else? The plan, the employer wins because, again, we're trying to bend that cost curve. We're trying to save them money, but give their people access to great care. It's the classic triple play. The providers, the payers, and the patients all winning in our scenario. And what we've been talking about this whole time is about parts and pieces of that to give them the care they need at a price that's affordable when they need it. So that's awesome. Well,
Yeah.
we've talked a lot, and you and I have talked a lot over the years about, healthcare. And is it broken or is it not broken? How do you define it? Is it really broken? No, it's really working exactly like those that designed it, the health systems and the insurance companies. It's working perfect for them, but it's not working perfect for the payer, the provider, and the plan sponsor. So, it's optimized for the wrong people in essence. And, everything that you stand for and everything that we're trying to build in these plans, one word is really important because we're trying to bring that back into healthcare. And that word is empathy. How would you define empathy as a metric? We talked about quality metrics and it's like, okay, all over the map, but how about empathy as a metric? Tell me a little bit about what you think about that.
No, I love it. I love it, and it's empathy is hard to measure as a metric. Yes, it should be, but yeah, come up with a solution on how to measure that. But empathy, again, it goes back into doing something in a manner to number one, understand and reflect the emotional position that patients and or employees are in. If an employer can do that and say, I get how difficult this is, I get how frustrating this is. But then rather than to just say, but there's nothing we can do about it, that's where we lack empathy. Empathy says, I'm not just going to complain, I'm going to come with a solution. Okay. And we're going to build a solution around making sure that those pitfalls are thought of and they're fixed. And can we overhaul the entire system? Absolutely, we
Now,
can't. I mean, we know that. We can't overhaul it. And in many ways, I don't want to recreate or create these solutions to get around it, but we can redesign it, and we have redesigned it in many fashions from primary care up um, to provide an entirely different experience of healthcare. Um,
absolutely.
and I would say when, again, going back to that employer, he expressed empathy in a manner of saying, I hear you. I hear what you're saying. I hear your frustration. I feel your frustration with you because ultimately he's seeing money go out the door and feeling no value for it. Nothing's
Right.
changing. People
Absolutely.
aren't healthier. They're not happier. They're not
Mhm.
satisfied per
That's
se
right.
with the healthcare experience. And he said, I hear you. I hate this healthcare system and this healthcare experience.
Yeah.
And I've found at least one solution that I would like to adopt that matches that. And that to me is empathy. Measuring it's difficult,
Yes.
but I would say measure it in your absenteeism rates, your satisfaction rates, um, and even your plan participation rates.
Yeah. Correct.
Yeah. You
That's
know,
awesome.
looking at, here we are in renewal season and looking at the costs and everything. In general, primary care claims make up about 5% of the total spend, generally, is what we think of industry average, about 5%. Um, if you looked at your current as employers out there, you look at those premium dollars and think 5% is going to primary care. What is that dollar amount? And if I had that same dollar amount to go procure it in a different fashion, what would that look like?
Right.
Those are the questions you should be asking. How can I use that same 5% of dollars? Which, by the way, this is kind of interesting too, Troy. We broker, we know this. What's the average commission on a small group account in insurance?
5%.
So to sell a product that doesn't deliver any care is going to equal the whole value of billed services for primary care. We have a problem.
Right. Absolutely.
We have a problem. And so yeah, I think it's looking at okay, we've budgeted and or we're spending this amount on quote unquote healthcare or healthcare product. What are we getting for it? And in any other piece of your business that you weren't satisfied with what you're getting, you would change it. You would change vendors. You would change salespeople. You would change whatever it took to make sure that your dollars were returning to you in some form of a value. And I think employers across the board right now don't feel value.
Right. Absolutely.
They
So
don't feel
true.
it at all.
Yep.
Unless they own
Well,
their plan, they're
yep.
self-funded, and they have the incentives aligned so that their people are winning, the patients are winning every day, they don't feel value. But to those that are doing that, they're happy, they're healthier, and they're fun to work with.
That's right.
Yeah.
Absolutely. So true. Well, we talked a lot about the system today. We talked about some of the hindrances and how, these relationships are challenged because of the alignment or misalignment of incentives. But let's end on a story, Jonathan. Tell me a story, a patient story where it worked, where the system came together. Maybe it's our system, maybe it's DPC, but the system worked and the patient won? Tell me one of those stories.
Yeah, again, we get these quite a bit. Um, I had an individual just a few months ago came in atrial fibrillation, but not only atrial fibrillation, they're in thyroid storm, which means they have hyperthyroidism, which has led to the atrial fibrillation. We're in serious trouble. Okay, and there's no plan design that can fix this right now. This is what I say the healthcare system, if you will. I need to know that locally I have somebody to call, a place to send them, a trusted colleague that's going to know what to do when they get there.
Right.
And through that process, recognizing what was wrong,
Right. Yep.
making a quick enough assessment to make that phone call, and then literally helping to get the transport arranged for them to get into the ER. And we knew what the problem was. You know what I'm saying? We knew what the problem was,
Right.
couldn't fix it in that specific setting. But I made a phone call to the ER. Dr. So and so, hey, I've got this gentleman in my office. This is what's going on. This is the history. Has been off some meds. That's why we're this way. Weren't taking the medications.
Wow.
Unfortunate. It was
Yeah.
avoidable. Uh, but yeah, then the ER's calling me back an hour and a half later, giving me updates. It's good care. They're saying, hey, this is what we found. This is where
Right.
we're at. This is what we're doing. And through the course of that hospitalization, there's communication from the hospitalist telling me what's
Mhm.
going on. I'm getting
Right.
records, but they're also calling me saying, hey, here's what we've discovered. This is what we're going to do. By the time this member of the self-funded health plan in this case, by the time this member left the hospital, we had enough communication locally in our delivery model.
Right.
We'd had enough communication for me to know exactly what was going on, exactly what he needed. He had the meds in hand that he needed. And guess what? We are now in a position that we didn't have one further complication, and we're also in a place now that we've managed him extremely well. And so this could have been an absolute nightmare, and the system worked, you know? But I would say the key component there is the time that was necessary, the availability, and then thirdly is the communication. Not really
Right.
thirdly, but a part of the big picture is communication. Um, and and on a local level, we get that. I do see when we send people out of town that the communication almost disappears.
Yeah.
We'll get notes, but
Right.
we just don't get the phone calls. And I love being involved in the care, whether I'm bedside in the hospital or in the clinic. I really like to know what's going on and be involved in the care.
That's awesome. And think about the experience for that member. Guess what? He didn't have an extensive stay at the hospital. He
Correct.
didn't have a cardiac arrest or something bad happen where
Uh-huh.
his life was altered. He had a good experience. Yeah, it wasn't the best in terms of had he made a different choice, but it was a whole lot better than the alternative.
Absolutely.
That's awesome. That's great. Well, every chart, every policy, every benefit exists to help someone get well. That's the intent. And real change is when we start and remember that it's a person. We're dealing with the people. And that's when patients win. When remember that it's about people, the patients win. Because until the answer is yes, we're not done. We've got to remember it's about people. See you next time.
Take care, Troy.